Hi, I'm Isaiah Pominville, and I am going to talk about how to succeed as a new clinician, and give you a framework for thinking in, early career as a PT. So this is aimed at new grads, at student physical therapists, or at anybody who's just kind of struggling and wants to kind of up their game a little bit with a new framework thinking. This can help really to build your confidence in everything that you're doing. And essentially, you can really easily build off of this. All right. So, evaluation basics is the first topic here. And we're going to kind of go through my thoughts on an eval. Okay. So, what makes a good eval? I think these four things are the biggest thing that makes a great eval. And this is not necessarily in order of importance, right? So, diagnosis, interventions, patient education, and rapport and buy in. So for diagnosis, we need to gather the information needed to create a working hypothesis for a diagnosis. And if you're having a really hard time creating a diagnosis, you can say shoulder pain. That can be your diagnosis. Okay. Every once in a while, I have somebody who just everything hurts. So it's hard to really come to a diagnosis. I can't really do any testing. The objective, history taking didn't give me a ton of information. Shoulder pain is what I'm going off of. It happens sometimes. All right. Interventions. Use the working hypothesis to generate 1 to 3 interventions or exercises to try in the session and then to give for home exercise program. All right. We're going to talk a lot more about this in a little bit. Patient education. Very important. We need to let the patient know what's wrong with the diagnosis, how long is it going to take to get better. That's the prognosis. And then what the plan of care looks like. What is the roadmap of getting better? How does that look? What can they expect for interventions throughout the plan of care? A rapport and buy-in, this is also extremely important. All right, so you need to listen to your patient, you show genuine concern, and communicate well. Okay, creating that trusting therapeutic alliance with your relationship is huge, and we'll talk a little bit more about that later. Another thing here is demonstrating confidence that this individual will get better. And there's a difference between showing you're confident that you will get them better versus showing the confidence that you will help them get better. Okay. Just kind of semantics there, but I think it's an important distinction that we should make. So being confident that the patient will get better is really important. I think it really helps to leverage patient expectations and beliefs, which is really important, and we'll find that out later. We'll talk about it a little more, but I have a few sources there about the buy-in, and that's basically what those sources are saying, is that patient expectations and beliefs are huge in patient outcomes. So building up that rapport and the buy-in, getting the buy-in from the patient is really important. Now, for a subjective history, it is absolutely crucial to conduct a thorough and thoughtful subjective history. Evidence has shown that, somewhere between 75 and 83%, and maybe more of the time, the history alone can lead to the correct diagnosis, even without any objective testing. Look, if you're horrible at objective testing, this kind of shows that as long as you take a really good subjective history, the objective testing may not be that important all the time. Now, it's also important to recognize that sometimes you come up with a diagnosis with a subjective history, you do the objective testing, and you prove yourself wrong. It happens, all right? So you can't completely trust just one thing or the other. But I'm just proving a point here that it's really important to conduct a good, thorough subjective history. All right, now, in my opinion, the most basic eval subjective should include all of these things. So symptom details, ags and eases, onset details, when did it happen, mechanism of injury, how has it progressed since then, prior level of function, current level of function, what are their goals, and then, talk about any relevant imaging, health conditions, diseases, past injuries and surgeries, things like that. Now, nutrition, water intake, sleep, and stress, those things are not always completely necessary, but they can be really helpful. All right, so we're going to talk about each one of these things. So symptom details. Where exactly are the symptoms? We need to rule out other body regions. Okay, so if they're saying they have shoulder pain, do they have pain down the arm? Do they have pain in the neck? Like, what else is going on? Is it just the shoulder? Is it a specific spot in the shoulder? Something that can be helpful is to point to the area of pain. If they can put one finger on it, that might give you a hint of kind of where symptoms are and stuff. If it's, numbness, tingling down the arm, then I tend to think a little bit more towards a cervical radiculopathy type of thing, right? So remember that things aren't always the way they seem. So if somebody's saying they have a lot of shoulder pain, make sure you rule out other areas, because maybe it's a cervical radiculopathy, maybe it's something else, right? So the next thing there is symptom descriptors. So is it numbness and tingling? Is it a burny? Is it a deep achy pain? Is it clicking or clunking in the knee? Does it feel like it's getting locked? All of these different things help lead us to the root cause and to our diagnosis. Irritability of current symptoms is also really important. So how much does it take to aggravate the symptoms? How much does it take for the symptoms to calm down? So these things can help us to get to the root cause and help guide the objective testing and interventions. For example, if I have somebody who is super irritable, doesn't take hardly anything for symptoms to be aggravated, and it takes a long time for the symptoms to go away, I'm not going to do a lot of provocative testing. Right? Low back pain, can barely stand for a few minutes. I'm not going to do a whole bunch of testing. I'm not going to make them, move a lot and do like a bunch of lifting and stuff like that. They're just not going to want to come back. We have to help our therapeutic alliance and our buy-in and our rapport with our patient as much as we can. But remember, we also do have to get to some sort of diagnosis. Okay, so in the instances where symptoms are very irritable, I like to employ the as much as necessary but as little as possible tactic, right? So you're going to be doing as much testing as you need to, but as little as possible, because you don't want to irritate the symptoms, okay? And it can also help guide the interventions a little bit. All right, so if they're super irritable, then you want to do things that are known to help reduce the symptoms versus things that might kind of push into the symptoms a little bit. I wanted to bring up a couple of concepts that can be really helpful to kind of just keep in the back of your mind, okay? So the first one is Occam's razor, which basically states that there is a bias towards simplicity, right? If you have a couple of opposing explanations, the one with the fewest assumptions and the one that has the simplest explanation is probably true, right? Not always, obviously, but that's more likely to be true, okay? Now, the other side of that coin is Hickham's dictum, which states that a man can have as many diseases as he damn well pleases. All right, so you need to pay attention to the whole picture so you don't miss things. Occam's razor can sometimes obscure the whole picture, but it often is very helpful to get us to the correct diagnosis. Okay, so just a couple of things to kind of help keep in the back of your mind there. Now, exegesis here. For efficiency, I usually ask, what are the top 2 or 3 things that seem to really aggravate your symptoms? And for eases, I just tend to ask, what are some things that you've tried that have helped ease the symptoms, right? So it's important to also note that you want to learn not only what makes it hurt, but how much of that is required to make it hurt, and how long does it take to go back to baseline. That's your irritability right there. Okay, so again, just kind of stressing the point of irritability. It's really important and helpful for your objective testing and your intervention choices. All right. And then your onset details. When did it start? What was the mechanism of injury? Was there a traumatic onset that caused it, or was it like a gradual onset? And how have the symptoms changed since then? Okay, so all these things are important, can help us get a better picture of what's going on and what the diagnosis might be, essentially. Now, prior level of function and current level of function, these are really great to help establish better goals. Okay, so asking things like how much and what types of activity do you do currently, including any exercise, leisure activities, walking, going to the gym, things like that. What are they doing now? How has the level of activity changed since they started the injury? What are they not doing now that they used to do? What are some things they're going to get back to? Would they be happy getting back to their previous level of activity, or are they interested in doing more? All of these things are really helpful for establishing those better goals for these patients. Right into goals here. So our level of function, current level of function, again, give you great personal goals that are meaningful to the patient. You want to avoid dead man's goals. Okay, so if your patient can reach the goals by being dead, they're not great goals. For example, eliminating pain. That being said, writing goals for pain aren't necessarily bad, but they just shouldn't be the main focus. Okay. Sometimes you really have to dig in and ask more specific questions to really get your patient why. Why are they there to see you? What do they want to accomplish? What do they want to get back to? And remember, you don't make goals for your patients. You figure out what the patient's goals are by asking them targeted questions, and then you can help them to refine those goals. Now, imaging, health conditions, diseases, past injuries, surgeries, all of these things are important to get a good picture of it. And a lot of it may come, the paperwork that you get, the intake paperwork, but I like to ask about them anyways. So, things like Parkinson's and MS, that can be relevant to the case and directly affect the treatment. Sometimes, they help with your diagnosis. So if you find somebody who has lumbar stenosis on imaging, maybe it matches your subjective and objective findings, then that can be a helpful thing, right? I think I'm going to do another post on, imaging and things like that. So stay tuned for that. Sometimes these other things can help drive the intervention. So if someone has like a fused lumbar spine, I'm not going to be doing a thrust technique on them. I'm just not. There's really no reason to do that, at least not in the lumbar spine. Sometimes these things help build rapport with the patient. So if they are giving you all these things that have been going on and they, sounds like they've had a rough go, right? Saying something like, wow, it sounds like you have a lot to deal with and you're a very strong individual. That statement right there, if genuine, can do wonders, can really help build that relationship, especially if you mean it. Sometimes these things are just good to know, right? So if your interventions don't seem to be helping, these other kind of things going on might help to clue you into more diverse differential diagnosis. So, maybe they have more things going on than just the thing that you think is going on. Or maybe you're wrong. Maybe your diagnosis is wrong. Maybe they have some kind of cancerous thing going on or something that needs to be referred out, right? So all of these things can be helpful for determining what you're going to do. And if things aren't going the way you would expect, then it gives you a clue into what else should be on the agenda for what to do next. So now here are some things that are also just helpful to ask, but aren't necessarily super important. Nutrition and water, right? Getting better nutrition and proper water intake can be really helpful for pain recovery and especially chronic pain, right? So I have a few sources there that show that. I usually ask about, protein, fruits and vegetables, and water intake. It's often not something that I spend a lot of time on, but it can be something that can be helpful in terms of just providing some education. I'm not going to sit there and lecture somebody on how much protein and fruits and vegetables and water they should get and all that stuff, but just mentioning it, and especially mentioning it that it has an impact on pain, can be something that resonates with people, and they might be like, oh, I didn't even realize that. Maybe I should change my nutrition habits a little bit, right? And so that's where that can be really helpful. Sleep and stress is another couple of things just like that. Basically, it can be huge drivers of pain and disability, and they can be difficult to actually change or improve. But I always mention that because it's another thing that it is a modifiable factor that can help improve your pain, right? So they're not easy to change, and it's something that maybe you'll have a little bit more of a talk about, especially if the person in front of you seems like they're getting horrible sleep or they have really stressful life. Just having a conversation about that can be something that's helpful. So again, not super always necessary, but can be helpful for your education and things like that. Okay, so this here is my version of my eval form. So for almost all my evals, I have a clipboard, I put this on it, and I write out everything. It helps keep me organized and it keeps me on task. So I think what I'm going to do is in a future video, I'm going to go through a mock eval with the patient. So I'll show you exactly how I do it, and I'll show you my, kind of what I'm writing down on the sheet as I go, because that might be helpful. And if this is really helpful for you, I would definitely recommend using it. All right. So now we have the objective portion. By the way, before we talk about this, I do want to mention that once you finish filling this form out, you're talking to the patient, you've fill this form out. You should have a couple ideas for hypotheses. If you struggle to go right into your objective, which I did for a while, and I still sometimes will take this time out, I would recommend taking 5 minutes and just say, I'm going to gather a few things. I'm going to gather my thoughts. I'm going to kind of plan out exactly what I want to do for testing, and then I'll be back and we'll work on that. Okay, so I would recommend taking 5 minutes in between. Breathe a little, talk to mentors or other PTs there to bounce ideas off them and see if they have any ideas. Sometimes I go to Google and look up things, and that just helps me in the objective testing a little bit more, right? So early on too, what I used to do is take this sheet of paper, flip it right over, and literally write out a plan of what I want to do. For example, I would do passive range of motion, active range of motion, MMTs, the specific tests I would write out, like a slump or a straight leg raise, things like that. All right. So write out that. And then also I recommend writing out a few ideas of interventions, even if you don't know exactly what's going on yet. Have a few ideas so that you can seamlessly kind of transition into trying those. Okay. All right, let's talk about the objective portion. So the goals of the objective portion of the eval are to refine your diagnosis hypothesis. So something that can be really helpful, you have all of these diagnoses, right? And it sometimes can be overwhelming with so many things that you can, choose from. And it's like, I don't know if I remember all of that, and I don't know if I can come to the right conclusion. But what I found to be really helpful is these two things right here. So the first thing is think about whether this issue is contractile or non-contractile. If somebody has pain with active range of motion, but no pain with passive range of motion, for example, if they do bicep curl and it hurts a lot, you do MMT for the bicep and that hurts, but you move through the range of motion, especially shortening it, and it doesn't bother it at all, it's more likely to be a contractile tissue, right? So probably the muscle or the tendon. So that's one way to think about it, just to start to narrow it down, and that can help you in your interventions as well. The second piece of it is intra-articular versus extra-articular. Is it within the joint capsule, or is it something outside of that? So, and oftentimes, the things outside of that are things like the muscles and, tendons and other things like that, nerves, things like that. So intra-articular versus extra-articular is something that can be helpful to think about as well. Other goals of your objective portion of the eval are to find the objective measures to track progress over time, right? And then also find an objective measure or a test retest specifically for interventions. So if you find a couple of things that are quick and easy to test and are positive or, painful or whatever, but are easy to test after some sort of intervention, that can be really helpful for buy-in, right? And I think we'll talk about this in a little bit. Here's basically a list of things to look at, what I look at most of the time. There are other things included in there, like sometimes I'll look at how they walk, their gait, and things like that. It's very dependent on the person. Most of the time, these things are the biggest things to look at, right? So active range of motion, passive range of motion, and actually measure with goniometry for a test retest and for tracking progress. It can be really helpful. Now, I understand that, it's not super specific and it's okay to estimate sometimes, but for a test retest and for tracking progress, it's pretty helpful to actually measure it, especially early on. And it's okay to estimate for like screening or for refining the hypothesis list. Not worried about that. Like if somebody has good range of motion, active, passive, I'm not going to go ahead and measure all of those things. It would be a waste of time. All right. So manual muscle testing and strength testing is another thing here. And when it's appropriate, consider using a handheld dynamometer. It can be really helpful for, test retest and just tracking progress over time and things like that. Okay. So other tests that I use, palpation, and I often just use palpation more for symptom reproducibility to help me, lead me towards some kind of diagnosis. Neurodynamics, so your tests like your tension tests, your slump, your straight leg raise, things like that. Orthopedic special tests when appropriate. And we know that orthopedic special tests are not great in terms of specificity and sensitivity. For the most part, yeah, they're not great, but it can be helpful sometimes to kind of help you to rule in and rule out diagnoses. All right. And functional tests when appropriate should be done. So things like a 30-second sit to stand, 6-minute walk test, time to get up and go, erg, balance scale, the functional gait assessment, things like that. All right. And then other than that, anything to help you track progress over time can be really helpful. Even if it's not a specific test that's been done before, just document it. So for example, I had a patient recently who couldn't stand for more than, 1 minute or so is what he said before the, pain in his back and down his legs goes all the way down the back of both legs and into the feet. Couldn't stand more than a minute. He laid down for the entire eval for most of the eval because it hurt so much and he couldn't sit or stand. So I didn't do a ton of testing. Basically, what I did for one of my tests was come on and stand up. Let's time how long it takes for the pain in your back to go down to the knee. Once that hits the knee on either side, go right back and lay right back down. So having that can be a measure of success. So in the future, if, I think the time was something like 45 seconds or something like that. So maybe next time we do a progress note, if he's able to stand up for 2 minutes now before the pain goes down to the knee, that's progress. That's huge. That is really helpful for the patient's buy-in, for the expectations and beliefs and all those things, right? So we'll talk a little bit more about those things in a future video again, but these things are really important. Okay, now test-retest. This is an important concept that can be really helpful. All right, choose a symptomatic objective measure for the test-retest. So try an intervention and include some education about why it might be helpful. Then retest that objective measure for any positive change. Now, keep in mind that when this works, when you see immediate change, even if it's small, it can really help with your buy-in. Now, keep in mind, it's not always appropriate or helpful. It depends on what's going on. It depends on the patient. It depends on a lot of things, right? So when you don't see immediate results, I wouldn't recommend using this all the time with that person. Okay, so the interventions and the home exercise program. Ideally, you're going to give the patient 1 to 3 exercises for their home exercise program. And ideally, these are exercises that improve symptoms or function. Okay. And if nothing improves symptoms or function, exercises that gets them moving without an increase in symptoms is great. That's a win if you ask me. Okay. If you can get the person moving more, but they don't hurt more, that's a win. Okay. Common mistake that therapists often do is giving too many exercises for home exercise program, especially on the first day. I almost never give them more than 3 exercises for home, because what tends to happen is if you give too many exercises, the patient feels like the home exercise program is more of a burden, so they just don't do any of it. Right? So I always stress that something is better than nothing. So I want to find something that they will actually do, right? The best home exercise program is the one that the patient will actually do. Okay. So here are my references. Let me know if you guys have any questions, put them in the comments, and I will see you in the next video.